build collaboration between clinicians, scientists, and biomedical engineers. By hosting one lab each month, we give them opportunity to present their most interesting papers and showcase technical tools they use in their research. So please, next slide. The idea of this journal club originally was introduced by Professor Pelishsis. She is currently the president of NAMS. I have a privilege to be a director of this journal club. I want to thank our educational committee leadership, Dr. Ala El Sayed and Dr. Mark Malinovsky for supporting this initiative. A special thank to our coordinator, Sylvia Mesawuso, and our director of education, Amy Cathart, for helping me to organize and run this journal club. Sylvia, could you turn? Before we start, I would like to remind you the few rules of this webinar today. All of us gonna be muted during the presentation. Please write your question in the chat and we will be happy to address them after the presentation. After the end of the presentation, all of you are going to be unmuted and you will have opportunity to speak even go on a video. The webinar recording will be available on our website and our YouTube channel in 48 hours after webinar ends. Please, next slide. Today we're going to discuss if it's possible to predict response of high frequency spinal cord stimulation with patient with failed back surgery syndrome with machine learning techniques. I'm so delighted to introduce the first author of this paper and our presenter today, Dr. Lisa Godman. Dr. Godman obtained her master in physiotherapy in 2014 from Hen University, Brussels. In 2015, she started her PhD under the supervision of Professor Martin Moniz. We have a privilege to have him in the audience, even with a big time difference. In 2019, Dr. Godman successfully completed her PhD and started a postdoctoral training funded by Research Foundation Flanders in Stimulus Research Group, RIC, University, Brussels. Since October 2022, she is assistant professor in 3 University of Brussels. Currently, she is spending 6 months in Florida Atlantic University in a group of Professor Pelishsis with Dr. Ilkna Telkis. Dr. Godman, we are so happy to have you today. Without any further ado, please take away.
Thank you very much for the kind introduction and also for allowing me to present our paper. It will be about machine learning techniques and to see whether we can predict the response of spinal cord stimulation. And this paper was published already in 2020, so during the COVID pandemic, in the Journal of Clinical Medicine. But before I'm going to talk about the content of the paper, I would like to give some more insights about our research group. So next slide. Because we're a rather small group from Belgium, a small country. However, we're doing our best to do a lot of research within the field of neuromodulation. So next slide, please. The head of our group, so of Stimulus Research Group, is Professor Moens. He's a neurosurgeon and he's the founder of Stimulus, and Professor De Smet and I are the co-founders of our group, and we are the 3 persons that are running the group right now. So Professor Moens, I already told, he's a neurosurgeon at the University Hospital of Brussels. And he's mainly the one with a lot of brilliant ideas. He's the driver behind the group. And if you need a research idea, he will be always capable of providing new, fresh ideas. Then Professor De Smet, she's also a physician within the fields of rehabilitation medicine, and she's also a neurologist. She is predominantly busy with data collection and with guiding the PhD students we are working with. Then I'm the third person within our group, and I'm a statistician. So I'm doing the nerdy work, let's call it, and I'm mainly doing data analysis, data processing, and then writing the results within a manuscript form. We have two postdoctoral scientists who are working with us. First, we have Dr. Jorne Laton. He is an engineer, and he is partly working at the IT department of the hospital and also as a postdoctoral researcher within our group, but also within a collaborating group regarding artificial intelligence and machine learning in chronic pain, and specifically in multiple sclerosis. Then we also have Professor Samar Hatem. She's also a physician, predominantly working on chronic pain and electrophysiological measures. So we have a broad range of experience within the academic staff and postdoctoral scientists within our group. And then we have 7 PhD students. The first one is Dr. Billet. He is a physician, and in his free time, let's call it, he is conducting research and really going forward to obtain his PhD successfully. And he is predominantly focusing on neuromodulation. He's an anesthesiologist, and mainly on the influence of heart rate variability and the autonomic nervous system in relation to neuromodulation. Then we also have a physician, Dr. Schiltz. He's a physician specialized in rehabilitation medicine, and he is doing his PhD about frozen shoulder and the implications of clinical medicine. And then the third one, who is also a physician and a PhD researcher in his free time, is Dr. Gergier. He is working as an anesthesiologist in the team of Dr. Van Bijten, who you probably know because he wrote a lot of publications about high frequency spinal cord stimulation. And he's doing his PhD within our group, predominantly on occipital nerve stimulation. Then we have Jonas Callens, and he started on a PhD project that is really the focus of our research group at the moment. So he is working on getting patients back to work. So the mission or the vision of our research group is not to only focus on stimulation parameters, stimulation paradigms and things like that. We really want to mean something for our patients. So we want to improve the trajectory of a patient who is following a treatment with neuromodulation. So in his research, he will explore if you give a patient a spinal cord stimulator, can we improve capacity of a patient to return and to go back to work? Because we know a lot of patients will receive a stimulator, but they will not increase in functionality. So that will be the focus of his research. And then Elke and Fran, they are working on another project, not after spinal cord stimulation, but before spinal cord stimulation. So their focus is to optimally prepare patients before they start a trajectory with neuromodulation by tapering off pain medication, so opioids and pregabalin, gabapentinoids, and to see whether results are better when patients do not take any medication before they undergo a trial period. And then we also have Leen van Doorselaer. She is working on an RCT. She's mainly doing it together with me. It's some kind of a response because nowadays spinal cord stimulation is questioned a lot, and it is an RCT to compare head-to-head spinal cord stimulation versus no spinal cord stimulation, so a conventional treatment on a holistic outcome response. And those are really the things that we aim to work for, and we really aim to improve patient care, quality of life, and not only focus on stimulation parameters and things like that. We have publications, but not a lot on those topics. So next slide. We, as Stimulus Research Group, we closely collaborate with the neurosurgery departments of the university hospitals. So we have direct access to patients due to Professor Moons. But we're not a group who likes to work on his own. So we have a lot of collaborations within Belgium. I'm just gonna point out some of them. So for the health economical part, we work together with iShare because you can show the efficacy of a certain treatment, but you also need to ensure that the health economical part is really better. So that's why we have a collaboration. Also with AIMS, the group of engineers who are focusing on artificial intelligence. Also, for example, with the Anatomy Lab, but also with Pain and Motion, an international research group, and also with TOR. Those are a social group, but they have really cool tools like wearables so that you can track patients. And that's something that can be implemented within neuromodulation as well to increase the use and the capabilities of wearable devices. So next slide. One of the strongest things of our group is that we are currently running a couple of multi-center trials, and Belgium is really a small country. However, we are working together with 17 pain centers, which are both neurosurgeons, but also anesthesiologists who are all implanting spinal cord stimulation devices. And they are located all over the country. And we're together jointly sharing research projects and really collecting data together to make a difference for patients. And I think that's the strongest asset of our group. Next slide. We don't only work within Belgium, we also collaborate internationally. So we only pointed out the groups with whom we have really a strong collaboration. So the first one is the group of Professor Eldabe, so the James Cook Hospital. We worked a lot together regarding pain medication, also for registries. So we have a good collaboration with his group. Then also with the group of Professor Duarte from the University of Liverpool, also in the UK, mainly regarding methodological aspects, health economical aspects, quality of life related to neuromodulation. So we really like the collaboration with both groups. Then we really have a strong collaboration and a profound collaboration with the group in France, so the University of Poitiers, the group of Professor Rigueur, because we are working on a broad range of topics together, from neuromodulation towards hypnosis, towards all you can imagine related to chronic pain. We share and we collaborate a lot with that group. And then rather recently, we now have a collaboration with Florida Atlantic University with a group of Professor Pelizis. And as Dr. Devil already introduced, I'm now at her lab to further collaborate together on composite measures and to see whether we can change the outcome within the field of neuromodulation. And I'm really grateful that I can stay at her lab for the moment. And that's a very brief an overview of who we are and with whom we collaborate a lot. So next slide. But today we're going to focus on machine learning techniques. And the main thing why we need machine learning techniques, or for what it could be useful within the field of neuromodulation, is just to see, can we predict the response of a patient? Next slide, please. And it's not only a prediction that matters. Together with a group of friends and with a group of Professor Eldabe and Duarte, we recently published a more general idea. So for patient selection, it would be too easy if we just can say, this is a statistical model, and based on the model, we are 100% sure that that patient will be a responder. It's not that easy, we believe. So we think that there is a framework with 3 levels. And the first level, those incorporate the general indications for spinal cord stimulation. So as most of you are physicians, you see a patient and you know, based on clinical variables, but also on your own expertise, that will be a patient that is suitable for spinal cord stimulation. However, that's not the only thing. There are also a lot of psychological factors related to that patient. So if it's a patient with major psychiatric disorders, then maybe you're going to treat that patient first for that issue before they are considered for spinal cord stimulation. So the individual factors do play a role as well. Then it also depends whether you are a physician, for example, here in the US or in Belgium, because there are country-specific rules to get reimbursement from neuromodulation. For example, in Belgium, we do not have reimbursement if a physician wants to use intrathecal drug delivery for patients with cancer pain. And there are other countries within Europe where there is reimbursement. So that will also depend to treat or determine the treatment options that a patient is offered. Another thing, and that's quite often discussed within literature, is the trial periods. Some countries do have a trial period, others do not have a trial period. Within Belgium, we used to have a trial period of 4 weeks, and since 2018, it has been reduced towards 3 weeks. But that's quite a lot, since a lot of countries only have 1 week or a couple of days, or even no trial period. But those factors are all within the first level. Those are the specific factors that are known for that country and for that specific patient who is seeing a physician. But then we also have a second level, and that's really the individualized pain medicine treatment. You can have 2 patients with exactly the same profile within the first level, but one of the patients just wants to be able to go back to work. The other person wants to be able to go to the movie once a week. Those are 2 patients with a totally completely different profile. Their treatment goals will be different. So maybe that should play a role as well in determining whether the patient will be suitable or whether the treatment will be successful for that patient, because their goals and their definition of success will be totally different. Another thing, we can use prediction models to individualize pain treatments. And that's the thing what we are going to focus on today. However, we have to be aware that according to us, that's not the final level. We also have a third level that will play a role in the system of patient selection. For example, as a physician, you have a couple of studies running and all the studies are with one company. Then probably you will implant one specific device at that company and you will not consider the others because you are running an RCT or a longitudinal study. It doesn't matter with that specific type or device. So that might change your opinion towards which type will you use or implant. Also, some ethical considerations. For example, MRI compatibility is a hot topic lately within the literature. Are you going to use a device that is MRI compatible or not? Because it's a young patient or it's an older patient. Those are things that will probably pop up within your head, and those are located in the third level. So the bias that might be present and ethical considerations that you should take into account. And I think it's important to know that that's the full factor, and we are now only focusing on the second level of the framework, and those are the prediction models. Next slide. If I say machine learning, then I was always confused whether what is machine learning, what is artificial intelligence, is the one broader than the other? And to be honest, the global idea is artificial intelligence. And that's in fact a simulation of human intelligence, but by a machine. For example, if you have a robot and you give the instruction to statistical coding on your laptop that a robot should be able to walk, then that is artificial intelligence, because the robot is able to walk, so the robot is able to mimic human behavior. And that is all related to artificial intelligence, so it's really a broad spectrum. Then if we narrow down the spectrum, then we come to machine learning. And machine learning is the capability of using algorithms, and you have a data set, and the algorithms will learn to see the patterns within the data sets and then predict the results based on the algorithms and the analysis that you conducted, the response on a new training set. And that is machine learning. That's the subdivision of artificial intelligence. And then there is a newer field with a lot of developments lately, and that's deep learning. That's mainly using neural networks. So they really are used to think like a human, to be honest. They have a multi-layer structure within it to mimic the human brain. And that's a subdivision of machine learning with a lot of development. So probably the most promising results within the next couple of years will come from the neural networks. Next slide. We are today going to focus on machine learning techniques because that's what we did. And there was a broad division, so two techniques. We have supervised learning and the unsupervised learning. Within supervised learning, you have a cohort of patients. You have a couple of outcome measurements that you collected. You collected them at baseline, and you collect them also after a patient has received a certain treatment. And then your goal is, can you predict the response of the treatment based on the variables that you collected before a patient received the treatment? And that's the supervised learning, because you have all the variables and you are also aware of the outcome, and you aim to predict the outcome based on the variables that you collected in the beginning. The counterpart is unsupervised learning. We are going to start again with the same cohort. We have a lot of data before the treatment, but we do not know the endpoint. So we are going to use the data that we have and see whether there are patterns within it. Can we make clusters, and can we see how patients are grouped together? Are they groups, or are all patients just the same and all similar to each other? And often machine learning is called, it's a black box. You never know what is going in and what is going out. And if someone is telling that, then it's mainly due to the unsupervised learning, because you do not know the response, and the model can just do some super calculations that no one understands. Then it's probably related to the unsupervised learning and not through the supervised learning. So within our manuscript, we only use supervised learning. Next slide. Because we have data from a lot of patients. So our patients were located in 2 centers. So we collaborated with another center, with the center of Dr. Van Bijten, to have a more properly defined data set. We included patients with failed back surgery syndrome, or lately called persistent spinal pain syndrome type 2. And we only included patients that were treated with high frequency spinal cord stimulation. That was just a decision because we had most data available with that type of stimulation, but we could have done just a similar idea with another type of stimulation. The design, it was a retrospective study that we did. So we did not collect the data up front. We looked into the data sets of all patients within the 2 hospitals, and we collected all the data that was available. And on the slide, you can see all the variables that we collected. So we have a lot of baseline data, demographics. We collected the age of the patients. Is it a male or a female? The dominant pain location, was it predominantly back pain, leg pain, or was it really an equal contribution back and leg? BMI, whether they were smokers or non-smoking persons, their work status, socioeconomic status, blood pressure, also the number of previous spine surgeries that they already underwent, and then more details regarding the duration of their pain and the onsets. Another interesting variable was that we also collected the pain intensity, and we collected that before patients were receiving high-frequency spinal cord stimulation, but also at the last follow-up visits, meaning that we did not pre-specify a specific time point after spinal cord stimulation implant. We just collected the data from the last visit that was available. And that's due to the retrospective design. When we would have used prospective design, then we would probably have decided on specific time points that we wanted to choose. But now we used the last follow-up visit that was available. And we did the same thing for medication use and for disability. So for disability, we used the Oswestry Disability Index. And for medication use, we used the Medication Quantification Scale, the 3rd version, just to take all pain medication into account. And we did not aim to focus only on opioid use. We wanted to take all pain medication really into the analysis, and that's why we converted it with the MQS towards one numerical value that is a value for all pain medication and not only focusing on opioids. So next slide. When we want to use the supervised learning, we have our variables. We can define our cohort, but we also need to define the endpoint. Meaning we need to define how are patients doing after they receive the treatment. And we used several outcome variables. The first one that we used is a 50% pain reduction in the predominant pain location at the last follow-up visit compared to the baseline visits. And we could just take the difference, and you can use an absolute difference or a relative difference. And we decided to use the relative difference because when we are using an absolute difference, then it is easier to get a reduction of 50%. For example, if you have a pain intensity score of 8 out of 10, then it is easier, or it might be easier, to go to 4 out of 10 compared to a patient who has a starting score of 2 out of 10, and he needs to reduce the pain intensity, then it's towards 1. So we always used a relative one to take into account the difficulties if you already have a low starting value. So that's the first definition that we used, a 50% pain relief. That's often used within literature, but maybe that is too strong. And that's why we also used a 30% pain relief, just to see what will happen if we use that cutoff, because patients might still be functioning and be happy with the result. They might be satisfied if they already have a 30% pain relief compared to a 50%. The third outcome that we used is a reduction in pain medication use. And it might seem strange, we used a percentage of 41.2. That's because that value is a minimal clinical important difference that we previously determined for patients with failed back surgery syndrome. So that's why the number came from. And we think it's important not only to focus on the pain intensity, but we just wanted to see, can we also predict another variable? And because we had data for pain medication use, we used that one. We could have also used functionality, which would have been really relevant. But we have to admit we did not have enough data for the Oswestry Disability Index for all patients to use that as an outcome within the model. So that's why we were not able to use that as a forward outcome measure. Next slide, please. And the next one. Yeah, so those are the results for the pain relief. You can see the waterfall plot. So on the y-axis, we have the percentage of change from baseline towards their last follow-up visit. And if you can see on the horizontal line, so the 0 line, patients that are below the 0 line, they are indicated in orange, meaning they have not obtained pain relief at all. They are worse compared to their baseline situation. Luckily, there are not a lot of patients who are located on that side of the graph. And then in green, you have all the patients with the percentages of pain relief that they obtained. So if you look at the dotted lines, the first dotted line is located at a 50% threshold. And you can see that there are 52 patients who obtained the threshold and who are responders if we use a 50% pain relief as our outcome variable. If we lower our definition and use the second outcome variable, so a 30% pain relief, then we have 79 patients who are a responder and 40 patients who are non-responders. Similarly, for the pain medication use, we also used the cutoff, and then we saw that there were 60 responders and 58 non-responders within our data sets. So next slide, please. When we are using machine learning, we just saw that we had a lot of baseline variables. Then we need to find a way to select which variables will we take into account within the model. And that's called feature selection. So we used a correlation matrix, which is presented on this slide. And you can see the variables on a continuous scale. And we evaluated which variables are correlated with a percentage pain relief with our outcome. And as you can see within the graph, we had two variables that were statistically significant. So the percentage pain relief obtained during the trial period, but also the number of previous surgeries that a patient underwent. And those two came out of the correlation matrix. Then we also used univariate analysis as an additional tool to perform feature selection and to see whether there are other variables that are important to take into account within the models. And based on that model, also pain location was an important factor if we use pain relief as the outcome measure. So we conducted a similar approach for the pain medication reduction, also based on correlation matrices and also on univariate analysis. So this is always the first thing you need to do within the machine learning techniques, select which variables you will use. Next slide. So after that was done, we could really start the programming and see which variables are important for us. And those are the results that we obtained. So you can see that we used 6 different models. The first one that we tried out is logistic regression. That's in fact similar to a linear regression, but now the outcome variable was not on a continuous scale, but it was just binary. Is a person a responder or is it a non-responder for us? Then the second technique that we used is linear discriminant analysis. That's in fact quite similar to logistic regression, but the fitting procedure is slightly different. And in some situations, LDA may perform better than logistic regression, but it might be the other way around. So that's why we used both of them to see what is happening and how are they responding. So then we also have a classification tree that we used. And so the main idea behind decision trees, classification trees, is that you start with all the data, you have all the data together, and then you are gonna make a distinction. So you're gonna split based on a specific variable. For example, we're gonna split on age, the younger persons towards the left, all the patients towards the right. Then within our younger group, we are gonna split again based on another variable. And you are gonna build a tree like that based on the variables that are important within your model. And then at the end, you have a specific number of outcome variables. For example, we have 8 groups. Then you can see if I have a patient, you just need to follow the tree and see in which group he will end. And then based on the majority voting, you know that patient can be allocated to that group. So that's the idea of classification tree. And in fact, the 3 remaining statistical techniques are all relying on the same idea. So the bagging, or in fact, bootstrap aggregation, that's the same as bagging. For that technique, you have your data sets, but you are gonna use bootstrapping. So you're gonna resample your data sets to end up with a lot of data sets that look similar, but are not identical. They are all based on the raw data. And you are gonna build a tree based on each of the bootstrap samples. And the idea is to reduce variance and to get more stable responses. So that's the bagging. Now, there might be a problem if you use that technique and you have one very strong predictor in your data set, then probably the first split that you will make will always be based on that specific predictor because that's a very strong one. And that's why you could use random forest. That's a technique to decorrelate it. And you are not going to use always the same set of predictors. So compared to bagging, there you are allowing every variable that you have in your data sets to determine the split. But based on the random forest, you are only going to use a subsample of predictors, meaning that your trees will be different because not each time you will use that one strong predictor as the first split. And that's the idea, that you can have a lot of different trees that will be more decorrelated to get stronger results. And then the final technique that we used is boosting. That's really a slow learning technique. So we're not going to use bootstrapping. We only are going to use our training data sets. And the idea is you have your data set, you fit a decision tree, and then you have the residuals of that model. You're gonna build or you're gonna use another decision tree to fit the residuals of your model. If you have done that, you're gonna put that to your main model. rerun it, have new residuals, and use a new decision tree on the residuals. So that's really a slow learning technique, but that can have really great results. And those are, in brief, the techniques that we used within this data set to see whether we can predict whether a patient is a responder or not. You can see the accuracy, so that's determined as the number of true negative results, true positive results divided by all observations that we had. And then you can see on the right side of the table the confusion matrix. So you can see on the rows the predicted status, and then on the columns you have the actual status that is observed within our data set because we have supervised learning. And the results can be seen on the receiver operating curve. So you have the sensitivity on the y-axis, meaning the true positives. So the true positive divided by true positives plus our false negatives. And on the x-axis, you have the false positive rate. I know it is there specified 1 minus specificity, but in fact, your specificity is your true negatives divided by the true negatives plus the false positives. Meaning if we subtract that from 1, then we have our false positives. So on the graph, you can see true positives on the y-axis, false positives on the x-axis. What do you want to obtain? The true positives need to be as high as possible. So we want to be as high as possible on the y-axis, but we also want no false positives at all, meaning we want to go towards the left of the graph. So that most ideal point is the upper left corner. And as you can see on the diagonal, that's just the baseline at random, tossing a coin, then you are not predicting something at all. And then you really see for each statistical model that we used, the results based on or presented on the confusion matrix. Those numbers are lower compared to the 119 patients that we initially included because we have trained our model on 80% of the data sets. And then we used the remaining 20% to validate and to see how is our model performing on data that was not used to train the model. And if we go one slide back, then we can see the results of the 50% pain relief. That was the first outcome variable. Sylvie, can we just go one slide back? Yeah, great. And as you can see there, we are not reaching the upper left corner at all. We are really on the lower left corner, meaning that the sensitivity of our models is rather poor. And as you can also see in the accuracy, we did not did a great job to predict a 50% pain responder with the models and the data that we had at hand. Next slide. So on that slide, you can see the same, but with a 30% pain reduction. Yeah, there it is. And you can see a different pattern. Now we have a high sensitivity, but we also have a high false positive rate. So we are doing a better job. Yeah, it might be, but the results are not great. And if you look at the confusion matrix, for example, if we look at logistic regression, that's the first line, then you can see there that we have a lot of false positives. And that's also the case for the other models. So we might not be doing a great job to predict a 30% pain relief. It is already better compared to the 50% pain relief, but it's not really useful within clinical practice with the accuracy values that we obtained. The maximum value was 70%. Next slide, please. And there you can see the results if we are going to use medication use as a responder. And then you see a totally different pattern on the graph. So we have techniques that are capable of obtaining a proper value of accuracy. We have the highest value with logistic regression of 88%. And it's also visible within the graph. So you can see we are not in the upper left corner, but we are really reaching towards that result. Some of the techniques are also performing properly. Others have more issues on the validation set to determine the responder stages of a patient. And those are the results that we obtained within this study. So next slide, please. We have to admit it was a retrospective study. So the variables were collected within standard clinical care. And Our group most of the time conducts prospective study to have more control about the data, but this was not possible for this data set. So it's retrospective. We only used one type of stimulation, so this might be an issue towards generalization of the results towards other stimulation types. We also used the last follow-up visits, which is at approximately 600 days. So probably from a clinical point of view, there might be patients which demonstrated habituation, others not. So that could be present within the models as well. And then regarding the machine learning techniques, we use techniques that are quite common within the field, but we have to admit there is a broad range of other techniques that you could use as well. You could also not use the 80-20% technique as training and validation set, but you could use other techniques. So there is really a broad range of techniques, and they will probably all lead to different results on the same data sets. But I think the main question is, would we redo this analysis in exactly the same way, but with a prospective design, because we like that more to have better control on the data and to ensure that we have no missing values at all, or as low as possible. And if I'm honest, then I would say no. And I think Professor Moons will give the same answer. No, we wouldn't do it again. So next slide, please. Because we are now aware that the prediction models, it's only one specific part within the second level of our framework. And we are not capturing the full trajectory if we are only focusing on one prediction model, because we set our why, our outcome is pain intensity, or the outcome is pain medication use. But that might be not corresponding to the goal that the patient really aims to achieve. If you have a patient that doesn't care about pain medication, or that doesn't care about pain intensity, but really about functionality, then the model will be useless. So next slide, please. And that's why we really need to think, did we use the correct outcome variable within our supervised learning? And lately, there are a lot of publications from the group of Professor Rousseau, Pelizzi's, from the group of Riguard, from our group as well, to state that we cannot only use pain intensity. We should use pain intensity, but also a psychological variable and a quality of life variable and functionality, and group that within one outcome. And maybe we should redo the analysis, but based on that outcome, and not only based on, did we obtain the pain intensity reduction? And I know it is against our own paper that I'm saying this, but it's just a development that we are now aware of, that we really should have taken that into account previously as well. However, you might say, if you use a strict or one composite measure for everyone, then it might not be relevant for each individual patient. And that's an idea that was published by Roy Duarte and Robert Levi. They say you cannot use one composite measure for every patient. You should use one composite measure, so a combination of outcome variables, but based on that factors where your patient is scoring low ones. For example, if you have a patient with difficulties on functionality and pain medication, then you should use those variables as the outcome variable. And if you have a patient with psychological issues, then that should be incorporated as well. So meaning the outcome is individualized. And that will be a better response to fit within our framework, to fit within the second topic of individualized pain medicine. So those are just things. And if we are going to redo the analysis, then we will definitely use another outcome variable. We also want to use a classification. So we won't say it's a responder or it's a non-responder. We will use a continuous outcome to grade a patient on a level, and to not say, yeah, that patient reached the cutoff if it's just by 1%, yeah, that he was strong enough or not strong enough. So we really want to use the differences between each variable on a composite scale and not only on one outcome variable. Next slide, please. But then you also might ask the question, is artificial intelligence or machine learning really capable of changing medicine? And this was a topic of a journal club that we had last month with AIMS. So that's the group we are working together with for artificial intelligence. We are also located in the same office at our university. And the two leaders of that group have two different opinions. They are working on multiple sclerosis, but it doesn't matter what the population is. But their idea is, will artificial intelligence change the field of medicine within the next 10 years? One person said, yes, definitely. The other said, no, not at all. They managed to publish their ideas, and I'm briefly going to stretch out their ideas because they are applicable to neuromodulation as well. So next slide, please. If we see the yes field, then they state that within the medical field, artificial intelligence really improves diagnostic performance of procedures. It can improve or enhance the workflow, make quick decisions. So it will definitely change the field further on within the next 10 years. They also say that within the field of artificial intelligence, they are now working on making models that you can trust and that are explainable to people. So they want to avoid the black box models that we previously discussed and really create models that you can explain. You can explain which data is coming into the model, what is your model doing, and how does it come to a prediction. And that's the idea. They want to build trust because that might be an issue in relation to artificial intelligence. Another thing is that they aim to give more trainings in artificial intelligence to really, besides only explaining statistical analysis within the training of physicians, they also want to explain the basic principles of artificial intelligence so that clinicians are also capable of understanding what your models are doing in order to better help them within their clinical reasoning. And previously, there might have been a human-computer competition, so one-to-one, and see which one is making a better prediction for patients. But they are now growing and shifting towards a human-computer collaboration, so that they are working together, and then it's not you have to trust one or the other, but that there is really input from a clinical point of view into the model and into the trainings for artificial intelligence. They also say it's not only related to a computer that is stated in a lab and it's only a one-man show within a lab. No, they really want to explore it and generalize towards the real-world setting that it's really used in the clinic as well. And that's why they really said, yes, we are 100% sure that within the next 10 years, artificial intelligence will change medicine. And that's the same reasoning for neuromodulation. All the arguments are valid as well. So that's one point of view. That's the yes side. Then as a final thing, we also have the no side. So next slide. And they said, no, we are sure that artificial intelligence will not be capable to change the way we are working now. And that's because they say, you cannot know how large your data set must be. So within an RCT, you are capable of determining this is the sample size, but within artificial intelligence, that's more difficult. So we always say we need a large data set, but what is large? And especially if you are using EEG analysis or functional MRI, then you need a large data set, but no one is capable of defining how large is large. An additional point is that you need consistent and complete data. So if you are working together with a lot of centers because you need a lot of data, then you should have the same outcome variables and also complete data within all of your centers. And that might be an issue. Then regarding the GDPR regulations, there are a lot of concerns with sharing individualized data. So that might be an issue in relation to artificial intelligence as well. They are looking towards regulations like federated learning. They use a decentralized approach that might be safer for individuals. But it's still, that might give some issues, especially regarding data sharing with other institutions. Then they also have issues. You train a model on a specific data set. Will that be generalizable? For example, will our data set from Belgium be generalizable towards the US because we have a different trial periods? That's why they would argue, no, that's not the case. And that's why you cannot use artificial intelligence. Another point is you need to validate a solution. If you have a good model, you need to validate it through an RCT, they state. But what is the common standards? Then you will need to use clinical reasoning. But it takes a couple of years to collect a lot of data of a lot of persons within multi-center settings that are generalizable to compare head-to-head a clinical reasoning versus artificial intelligence. And then as a final argument, they say people do not trust artificial intelligence. They go to a physician to have a connection with the physician. They do not go to a computer and ask, will this be a proper solution for me or not? No, they really want the interaction with the physician. And those are the arguments why they say no, artificial intelligence will not change the field. Next slide. And that's the end of my talk. I'm really curious to hear what your opinion is. Will it change the field or will it not? And are we there yet? Personally, I think we need some time, and we need some time rethinking what is our outcome variable, and then redo analysis and see what we can do. But it might be possible that we will never get there. So I leave it open to all of you. Thank you very much.
Thank you so much, Dr. Goodman, for such a fantastic presentation. You gave an excellent introduction to AI and machine learning techniques. So a lot of things are getting clear. So, Sylvie, could you unmute everyone? I want people to actually talk. Sylvie, could you check for questions?
Yes, everyone is available to open their mic and speak.
Yeah, so while people are thinking about questions, and Sylvie, if you see a question in the chat, please let me know. Lisa, I have a lot of my questions. So first of all, the uniqueness of this paper that it was one of the first in a series of publication on machine learning. So your group is one of the brave ones. So, and you raised so many interesting questions and you covered them, but I want to reframe them again for the audience. So you mentioned about the pain score is not really being a reliable measure, a reliable outcome, which usually the way we think. So the functional goals are more important, and they help to actually personalize and build a composite score. So at the same time, about the trial and the interesting finding about your paper that you found more correlation with trials and outcome pain score than actually baseline clinical factors. So we need to think, do we need a real trial? And you mentioned your discussion about randomized trial that you finding in your paper the high correlation with the trials stimulation, but this randomized trial showed that we really don't need a trial. Yeah, so could you comment on that? Or I would probably I would be happy if audience have questions on that. So I think it's important to cover.
Yeah, thank you very much. Those are indeed the main points, especially regarding the outcome variable, that we will not use a pain intensity score alone, and if we would redo the analysis. And it's true regarding the percentage pain relief obtained during the trial, that was remained within our data sets. But if we saw the correlation plots, then it was statistically significant, but the correlation coefficient was equal to 0.2 or something. So meaning that it's only a low correlation. So I think we should not over exaggerate the value of that variable. It was remained within our analysis, but I would not state that it is the most important one. That's yeah, we could take into account. So I really should not use that as an argument that we should use a trial. there might be some indications that we should look at the percentage, and there might be some information in it, but I would not say that's the reason wherefore we need a trial within neuromodulation, just to use that value within the prediction models. I think we really need to redo the analysis and see whether it remains included if we change the outcome variable or not, and that we then have more arguments to state it's really valuable or not, just from a prediction point of view, not from a clinical point of view, of course.
Yeah, we need more poorly clinical trials and analysis like your lab does and other machine learning groups to actually accumulate more findings to see do we really need to do trials, because it's important, because if we don't need to do trials, it's a reduction of costs. So it's economically important. So, and the strongest finding is actually reduction in medical use. But at the same time, you used a so-called composite score. I mean, not just the opioid you said in the beginning, but like what is interesting for me and for everyone, why do you think medical use as the strongest finding? Because pain score is not so like the scales we use are not so strong. So based on the methods you use. I mean, there are so many layers to this paper we can discuss for another hour. I just want to throw some ideas for people to think and follow up with you after. So why do you think it's the strongest finding of your paper?
To be honest, I think patients have more difficulties with completing a pain intensity score than we imagine ourselves. Or it might be very difficult for a patient to say, for me, this is an 8 out of 10 or a 7 or a 9. For us, from a statistical point of view, that is a huge difference, and it can determine whether a patient is a responder or not. But for them, it is just one number on a scale. How difficult is it? For example, if you, you have something and a physician will ask you, what is your pain score? Do you immediately know, well, for me, this is a 3 out of 10. Do you have a scale in your head that you know, 1 is that feeling, 2 is that feeling, 3 is that feeling? It's so difficult, so subjective, and it's based on a personal scale, but also on your surroundings. Are there other people who are standing next to you? Then your score might be higher compared to when you are alone. There is nothing to help, no one to help you. Then your score will be lower because you know you need to cope with everything. So I think that might be a possible explanation, that the pain intensity score is too subjective and not stable enough compared to pain medication use, where we have more some kind of an objective measure, or patients are more stable on a certain dose, and the stability might be reflected within the models. Of course, I cannot make this a firm statement, but that's only a hypothesis about how we can explain the results, that we were better capable of predicting a reduction in pain medication use compared to predicting a reduction in pain relief.
Yeah, this is the true key point, because a pain score is subjective. That means it's lead us to the discussion, to ongoing discussion in the neuromodulation professional community and pain community, that we need objective measures and we need the systematic points of collecting these measures. So that means this is what I really, another thing which I want to emphasize, that, and you wrote in your discussion, that we need, it's lead us to the idea of digital health and wearables. And what is another thing which is interesting, that probably we are already at the point of hour, but just want to take a few more minutes to make an conclusion and hear your comments. So probably what I learned from this paper, that the data we have, the clinical information which we're collecting on the routine clinical care, is not the one which we can use to build robust machine learning models. And the idea of AI brings to reality another field, which is digital health and wearables. So maybe we need completely different type of data, which collected on a daily basis without really taking the time of the clinical visits just through all this objective catching of the data. And they can be more reliable to build these models.
I completely agree with your reasoning. On the one hand, indeed, we need more objective measurements because those are avoiding the subjectivity or the self-reporting of a patient. So wearables are more capable of tracking what is objectively happening with the patients compared to self-reporting questionnaires. And on the other hand, you clearly stated that we're not going to use a snapshot because that can be so variable, and we really need long time periods and observing what is happening when a patient is going home. How are they functioning? Can the wearables react normal patterns in daily living and not only focus on how is it on that specific time point with your physician, because it might be possible that they had a long drive towards the hospital and they're more anxious to see the physician or anxious for certain results and things like that. So I really do agree with both points, more objective ones and collecting them more on a long time periods in order to reduce the variability of just a snapshot.
Yeah, so I do have more questions, but yeah, hopefully I definitely going to follow up with you, and hopefully people who are attending live and watching the recording will join you, because there are so many interesting technical questions about why, and you did an excellent overview of machine learning techniques itself. Boosting, bootstrapping, random forest, and so on. It would be interesting to see why some of them perform better than others. So I want to thank you for coming and presenting today. I want to thank everyone who joined us today live. Thank you so much, and enjoy the rest of your day. Bye-bye.
Thank you very much.